screen. Welcome, everyone. We'll be getting started soon. If you want to just type in the chat where you're joining from, that would be wonderful. So that the video recording will be available to you or to any of your students or other colleagues that you'd like to share this with after the fact. You'll be able to do that. Also, the link to the digital slides was posted earlier, so you also can review those afterwards based on what you hear today from Dr. Adhikari. So I'm really pleased to introduce our guest professor, Dr. Laura Adhikari. She is a cytopathologist and surgical pathologist here at the University of Oklahoma Health Sciences Center. She did her training at Mayo Clinic, which is a small clinic in the Midwestern US that is quite well known, and also has practiced at the Washington University in St. Louis. She's very well trained and an excellent colleague, and has graciously agreed to share her cases with us today. And so, Dr. Adhikari, I'm going to allow you to share your screen so that you can begin to take it from here.
Thank you, Dr. Hassel. Let's see here. Okay, so we had a minor flood in our lab a couple weeks ago, and our whole slide imaging imager is down. So I had to borrow some slides that are already on Path Presenter. So these are actually all slides that have already been scanned in by other universities and other pathologists, and they were classic cases. So I thought that I would go ahead and share them with you. And these are the same slides that are available on for preview that you had access to. So I thought that we would start off with two of the more common tumors that we think of when we think of pink kidney tumors. So let's start off with our first case. Let's go ahead and zoom in. Let me minimize the window so you guys can see my screen. Okay, so low power, we have a pink tumor. I usually start off by looking at my margins and seeing that this is a partial nephrectomy. We've got some vasculature. Let's keep going around. Getting up into the capsule. I like to try and find the renal parenchymal margin. I'm getting some down here. Getting an idea on the interface, especially with these pink tumors. Looking at the interface between the normal renal parenchyma and the neoplastic cells. Let's look at these cells here. So we've got some moderate nuclear pleomorphism, some binucleation. Hopefully you guys can appreciate my arrow key here. some binucleation. We've got some larger, more bizarre cells. This specimen doesn't necessarily have really prominent nucleoli, but this entity can have it. There's some more binucleation. We've got some perinuclear clearing around the nuclei. It hugs the nuclei and then it fades as you go towards these plant-like cell membranes here. I think this is as close as we can get. If you can get any closer, you'd appreciate that the pinkness of these cells is slightly granular. And then going and looking at the interface, so as you guys can probably guess, that this is a chromophobe renal cell carcinoma. The interface between the neoplastic cells and the renal parenchyma is usually very fixed. You won't see a lot of intermingling of normal tubules up into the neoplastic parenchyma like we will see in oncocytoma, which we'll see next. So it's usually a very hard border. There's not a lot of intermingling, but if you do a CK7, you're not going to see these renal tubules up here inside the neoplasm. It's usually a very firm border. Things to appreciate is when we look at the eosinophilic cells, there's not a lot of change in the nuclear or the nucleoli as what we would see in clear cell renal cell carcinoma, where when you go to the pinker areas, the nuclei get more bizarre. In chromophobe renal cell carcinoma, they're pretty uniformly distributed between the clear areas and the pink areas. Does anyone have any questions right now regarding this entity? Okay, so let's look at an oncocytoma. Okay, so as we get closer, the normal kidney parenchyma is out here, and we have our neoplastic cells over here. As we look at the interface, there's some intermingling. I bet you if you did a CK7, you'll see some of the tubular cells deep inside the pink tumor cells, or I guess they would say neoplastic cells. And when we get closer, these cells have nice prominent nucleoli. They're not as raisonoid as what we saw on the chromophobe renal cell carcinoma. They can have perinuclear clearing, but it's not as common. Chromophobe is also known to have some microcyst formation. Let's go to lower power here. Most of these are filled with blood, but again, we've got some microcysts. Things that aren't tolerated in the diagnosis of oncocytoma are papillary architecture. If you've got any papillary architecture, oncocytoma is not compatible with that, and you should probably consider maybe a papillary renal cell carcinoma. Let's see. You can kind of appreciate that some of the normal renal elements are. It's a very soft border with intermingling of the neoplastic cells with the benign renal elements here. Let's see. I think as we go towards the middle of the lesion, these islands loosen up into like a myxoid or hyalinized type stroma. And this will give you that fibrous scar that you can appreciate on gross description of these lesions. Less common in chromophobe. It can be present in chromophobe, but usually you'll have a lot more cellularity throughout the tumor, whereas in a oncocytoma you'll have looserness as you go towards the middle of the lesion. I think that concludes oncocytoma. Does anyone have any questions? I guess we'll move on to the next slide. Okay, so I made a list off to the left here of notorious pink renal cell tumors, with the two most common being oncocytoma and chromophobe renal cell carcinoma. The easiest stain that you can do to distinguish these two entities from everything else is a CD117, which is also known as c-KIT. If it's positive, then you're looking at a chromophobe or an oncocytoma. If it's negative, it's probably one of these other entities. Other entities would include a high-grade clear cell renal cell carcinoma, because remember how I mentioned that as clear cell gets more and more high-grade Furman grading, it turns more pink. Another entity to consider is a type 2 papillary renal cell carcinoma. And then we're getting into the very uncommon entities, the hereditary leiomyomatosis, also known as fumarate hydratase-deficient RCC, tubulocystic RCC, SDH-deficient RCC, and the eosinophilic solid and cystic RCC. We're going to see some of these entities next. So here is our next pink tumor that you guys had in your slide deck to preview.
Laura, before you go on, there is a question
Yes.
in the chat about whether or not you would also consider LOT versus HOT. And I'm not right clear on what those abbreviations are.
I am not either. Would you mind spelling those out for us?
Kalyani, do you want to just unmute yourself and speak up? High-grade oncocytic tumor, low-grade oncocytic tumor, I would assume.
Okay. Those are more entities that I would use to describe like a wastebasket diagnosis. So after I have excluded all of these other WHO described entities, if it is an oncocytic tumor not otherwise specified, I would probably use that type of nomenclature, especially if it's got aggressive behavior, as in angiolymphatic invasion, really high-grade nuclei invading into other organs, say the adrenal gland. Then I could use the high-grade oncocytic tumor description. But when you have those characteristics, you're probably looking at a high-grade clear cell renal cell carcinoma. The low-grade oncocytic tumors, I use those pretty much on core biopsy when I am not too sure whether it's an oncocytoma versus a chromophobe, and I would like for them to go ahead and resect. I'll use the terminology of a low-grade oncocytic tumor. Also, you can use that term when you're looking at patients that have multiple bilateral oncocytic tumors. The Burt-Hogg-Dubé related tumors have kind of a biphasic chromophobe oncocytoma type morphology, and they do have a predisposition to metastasize. It's not very prevalent, but they can. So you can use the low-grade oncocytic tumor in that context. I hope that addresses your question. Okay, perfect. Thank you. Okay, so our next entity. Let's go ahead and take a look at what kind of a resection we have here. It looks like it's another partial nephrectomy. We've got some perirenal fat along the capsule here. It's very well circumscribed, low power, very circular. It doesn't look like there's much of an infiltrative border. As we keep following it around, let's see. So very well circumscribed. So this looks very low grade, very indolent. Let's find us some cells to get on the high power for. Okay, so the cells in this resection We've got some mild to moderate nuclear pleomorphism, but the nucleoli are prominent. The cytoplasm is very fibrillary, maybe some microcystic change with these clear vacuoles, almost kind of feathery with the eosinophilic change. It's not very homogeneous, like we'll see in our next tumor. But overall, the cells are fairly uniform. There's some binucleation here and there. So if you were to stain this tumor with a CD117, this would be negative. If you did a Pax8, so a Pax8 is a nice stain that I like to use to rule out a metastasis. Most renal cell carcinomas are going to be positive for Pax8, so I like to use this one. This tumor will be positive for Pax8. So this is an example of a succinate dehydrogenase deficient RCC. These tumors are associated with rare germline mutations in SDH subunits, A, B, C, and D. The subunit B is the most commonly deficient subunit. So we've developed an antibody to the SDH-B, so I've used that a couple of times. These patients commonly have a history of paraganglioma or pheochromocytoma or pediatric gastrointestinal stromal tumor. And the thing that's interesting is that they'll not just have one, they'll have multiple, and they may even have a history of maybe a malignant paraganglioma. They're finding more and more that these patients that have a previous diagnosis of malignant paraganglioma with resection is just an emergence of a new paraganglioma within the tumor bed rather than an aggressive malignant paraganglioma. So this is kind of a new entity. I've had 2 cases myself. Mainly when I was at WashU, we had a family that had this deficiencies and presented with some renal tumors. These tumors are mainly indolent. They've got bland uniform cells with nucleoli, as we saw. There are cytoplasmic vacuoles. They're not quite empty, but might have a slight pink tinge to the cytoplasm. And like I mentioned, these patients will have a negative or loss of nuclear staining for SDH subunit B. Okay, so of all renal cell carcinomas, these are very, very rare, about 0.5% to 0.2%. There's a slight male predominance, and if left alone, bilateral tumors tend to show up. These tumors can be metastatic. They're rare, but it can, especially if they're not resected. And those features are associated with high-grade nuclei, coagulative necrosis, and like I mentioned, delayed follow-up. Additional immunostains that I like to do is a Pax8 to mainly confirm that it is a renal origin. And then if you do an extended panel, they'll be negative for KIT, RCC, carbonic anhydrase 9, and CK7. Any questions before we move on? So let's see. I have to pull this from the slide deck. Okay, so here's our next interesting case. So let's look at the interface here. So we've got another, this might actually be a nephrectomy. Let's see. Got some nice renal parenchyma squished into the capsule from the tumor. Just follow it around. It's hard to tell if this is a partial nephrectomy or a radical nephrectomy, but overall, it looks like there isn't very much invasion into the renal parenchyma. It's confined to the kidney. It's got some hemorrhage. Let's find some nice clusters of cells so we can appreciate what kind of cytology we have here. So these cells are somewhat similar to the previous case. They have some racinoid, some nuclear membrane irregularity, prominent nucleoli, but they're fairly uniform in their size. If you look at the cytoplasm, it's much more granular, homogeneous. As we look around, let's see if we find any cytoplasmic inclusions. There might be one there. Let's see. There's one there. So I'm trying to point out the trademark of this lesion. So there's some in here. Sometimes they can get a little bit bigger and a little more prominent. There's some more here. Just these little pink eosinophilic cytoplasmic. Some of these are RBCs, so we have to be careful. Yeah, here's a nice one here. Okay, so again, let's go back. So this is an example of eosinophilic solid and cystic renal cell carcinoma. These tumors are again associated with the syndrome, tubular sclerosis complex. They can be sporadic as well, and if they're sporadic, they're most commonly seen in women. I think over 90% of the documented cases of this neoplasm are women. Germline can be men or women. On histology, the cells have voluminous eosinophilic cytoplasm with coarse basophilic cytoplasmic granules, as we pointed out in our tumor. Or basophilic stipple, sorry. These are the eosinophilic cytoplasmic granules here. These tumors are positive for cathepsin K with focal CK20 positivity, and this is nice because not many other pink renal cell carcinomas are going to be positive for CK7. These tumors are also going to be negative for CD117 and CK7. Okay, so the number of tubular sclerosis patients that present with this tumor is about a third. Like I had mentioned, all sporadic cases are female. There is one or two documented reports of males having this neoplasm, but for the most part, they're all female. On karyotype, they've got copy number gains of chromosome 7 and 16. They also have losses of their X chromosome. These tumors are also going to be positive for PAX8. So I put together a chart for you all that kind of just quickly discusses the differential diagnosis. Here's the eosinophilic solid and cystic RCC and the immunohistochemical findings that we had gone over. I just wanted to also interject that epithelioid angiomyolipoma is in the differential, especially if it's fat depleted, and those will be positive for HMB45 and negative for PAN-CK and PAX8. So that's another hint that you're probably looking at a different entity. We've gone over Chromophobe and Oncocytoma, and then we'll go over these two lesions, and we've we did touch on SDH-deficient RCC, but we'll cover papillary and clear cell in a minute. Are there any additional questions?
So Laura, is it known what's in those eosinophilic globules? Are those a particular protein product from one of those defects in the pathways?
Yeah, it's just condensed, I think tuberin.
Okay.
Tuberin and I can't quite remember I want to say it's fibrillin or some, but it's condensed of these mutated deficient proteins.
Great.
So let me pull up. I'll have to go the other route. So these, like I said, these are all in the slide deck on Path Presenter. Let's see here. Let's go back. Let's just open it. So I go into the side library, high yield cases. So this is where I'm borrowing these cases from. Renal pathology. So we want this one, fumarate hydratase deficient RCC. These are excellent resources for you all if you have access to them. Okay, so this tumor, so you can tell right away that we're not in kidney. We're looking at a metastasis. So we already know that this is a very high grade tumor. It's already metastasized. We're not even looking at kidney anymore. Okay, so let's go in high power. Again, very pink eosinophilic cells, voluminous amounts of cytoplasm. As we keep going higher power, we've got these fibrovascular cores lined by these malignant cells that are very pleomorphic, very prominent nucleoli. I've seen 2 cases of this, and most of them are very cherry red, which we can't quite appreciate on this case here, but cherry red nucleoli is kind of a trademark of this neoplasm. It's a very aggressive disease. Quite frequently, these patients present with metastasis, distant metastasis at the time of presentation. Got some necrosis through here, cell dropout with apoptosis. Again, very high malignant cytology, bizarre nuclei, very papillary architecture, infiltrative. You'll also see some LVI in these neoplasms. Having a hard time saying leiomyomatosis this morning. There it goes. Hereditary leiomyomatosis. There we go. It's an autosomal dominant condition. It's due to a germline mutation in fumarate hydratase. These patients are usually young. If they're women, they'll have a history of uterine fibroids. Men will have maybe some cutaneous related smooth muscle neoplasms. They've got very prominent cherry red nucleoli with perinuclear halos. They can closely resemble melanoma or CMV or type 2 papillary RCC. They've got multiple architectural patterns with most of the pattern being papillary. They've got a very poor prognosis with 50% of metastasis at the time of diagnosis. So this is a very aggressive disease. most patients are dead 2 years out. So it's very important that we try and catch these early, especially for the family members, so that they can be under active surveillance. Is there another question in the chat? Let's see.
Yeah, they want to know if we'll be able to get access to this presentation, and I believe that the link to your presentation was shared, is that, or will be shared? We just shared the cases initially. We can share the link to your presentation afterwards.
Yeah, definitely. And I'll reveal the names to these slides. If you want to go back to the original slide deck, I'll go ahead and take off I guess the screen so that you guys can see the titles. But like I said, I borrowed all of these slides from Path Presenter, so you'll have access to them on Path Presenter. It's very nice, the library that they have there. So even though our slide scanner is down, I'm still able to deliver an excellent presentation to you guys because of the wonderful resources. Okay, so this is our next entity. Is there another question?
I'll take care of that one. Yeah.
Okay. Okay, so this is a clear cell renal cell carcinoma, and I wanted to show this mainly to help us think that when these tumors get really high grade, they really do start turning pink, and they can actually start becoming more rhabdoid. So under the Furman grading, rhabdoid can be classified as a grade 3 based on the nucleoli. But if you look at the new ISIP grading system, which came out in the WHO in 2016, rhabdoid and sarcomatoid differentiation in clear cell renal cell carcinomas, it automatically classifies these tumors as an ISIP grade 4. So there's just a subtle difference between Furman grading and ISIP grading. And ISIP grading, they only pertain it to clear cell and papillary renal cell carcinomas. You can't use the ISIP grading for any other tumor type because it doesn't necessarily correlate with prognosis. When Furman created his grading system, he applied it to renal tumors of all subtypes. But like, for example, with chromophobe renal cell carcinoma, you could actually have a Furman grade type 3, but those tumors behave so benignly that ISIP has just decided that they don't get a grade because they're falsely cytologically more aggressive, even though they behave very benign, if that makes any sense. Okay, so we're looking at a clear cell renal cell carcinoma. When we're looking at these cells, some areas they're starting to fall apart. It kind of is looking more reminiscent of the lung, where we're looking at maybe some alveoli with some histiocytes in the middle, but these are actually tumor cells. They're eccentrically placed nucleoli with maybe some nuclei with a prominent nucleoli. Pink eosinophilic cytoplasm. They're not very cohesive anymore. So this is a great example of rhabdoid differentiation. And then let's look at some necrosis. I thought that this had an excellent example of, oh, here's some fat. So whenever I see fat inside of my tumor, it's automatically a grade 3 because we are now invading the renal pelvic fat. So this is a AJCC grade 3 at least. Let's try and find some great necrosis here. So this is that great tumor necrosis that we have a geographic pattern. It kind of reminds you of the continents floating in the oceans. They're not very wedge shaped. When you have coagulative necrosis, when you have a dropout of a single vessel and all of its supplying vessels no longer support this tumor cell, so they all die. Whereas in true tumor necrosis, you'll have this perithelioma growth pattern where the tumor cells are clinging to the vessels, and as you get further away from the vessels, you'll have cellular dropout. So this is very different from coagulative tumor necrosis, which isn't included in the tumor grading. But we really need to look for this tumor necrosis subtype before we mention that there is a tumor necrosis on our synoptic reports. Was there another question? Dr. Hassel shared our link. Okay, perfect. Let's also look at the interface of the tumor with the normal renal parenchyma. We can see that it's starting to get down into the hilum. We're getting some nice tumor abutting into larger vessels. And in here, looks like we've got tumor actually invading into a vein. You can see the valves here. So this is an example of large vessel LVI. Now we've got more perirenal, or sorry, hilar sinus fat invasion, which was staged as a 3. Okay. So this is a high-grade clear cell renal cell carcinoma, ISIP grade 4 with rhabdoid morphology. I included this one just kind of in contrast to the higher grade clear cell renal cell carcinomas. This is your classic conventional renal cell carcinoma. There can be some binucleation, so just appreciate that and do your stains if there's any concern that this could be a chromophobe. We're running out of time, so I'll move on. Here's another clear cell renal cell carcinoma. I wanted to show this one because this one actually looked like it had some invasion into the renal pelvis. And if you look in the space here, it looks like it's lined by urothelium. So my mentor at Mayo Clinic actually designed the Eurovision fish study. And it's funny because back when he was developing the test, he had a clear cell renal cell carcinoma actually exfoliate into the urine a lot more often than it does nowadays. So this would be a great tumor that will probably see tumor cells in the urine specimens. So I thought this was an interesting case because I don't see this very often where it's actually invading into the renal pelvis. Next case. So it looks like we have a partial nephrectomy because there's ink. Hugging the tumor, getting really close. Bit into it a little bit there. But let's look at the tumor cells. Got some nice fibrovascular cores lined by predominantly clear malignant cells. We've got some stratification to pseudostratification, and then we have these nice little islands of histiocytes within the fibrovascular cores, which now puts us into a papillary renal cell carcinoma. And I wanted to mention this because papillary renal cell carcinoma very commonly does have coagulative necrosis. So not to be, again, confused with tumor necrosis. So even when you see coagulative necrosis, it's not going to be as associated with a poor prognostic outcome as if you were to identify tumor necrosis. So I usually tend to leave coagulative necrosis off my reports because sometimes it confuses my clinical colleagues, but it usually does not infer a poor prognostic outcome in these patients, especially papillary renal cell carcinoma where it's a common thing. Okay, so this is a nephrectomy specimen. I just wanted to mention that when we're looking at the renal vein, and if we have a renal vein thrombosis, a lot of times the surgeons will have a little bit of a lip around the tumor. I try to shave that lip off because if there's any free endothelium, that makes the margin negative. Our surgeons on some occasions will actually submit an extra ring so that we can go ahead and say that that renal vein margin is negative. But just because you have this big thrombus going out into the IVC, we really need to evaluate this thin rim of endothelium lining the renal vein. And quite often it's actually a negative margin. Okay, was there another question?
Yeah, Laura, Kalyani asks if there are any clues that would point to urine exfoliation of clear cell renal cell carcinoma. Would you usually expect that to just be sort of atypical cells for the Paris system, or would you report that as some other category?
So I've only seen this once, and the thing that how we caught it was that the Eurovision fish was positive, and they went back to the urine and pulled it. These patients now are being caught so much sooner than they were historically when the Eurovision fish was developed. But the cells, when they exfoliate into the urine, are usually very degenerated. So they will still have larger nuclei than the normal benign urothelial cells, but it can be very hard to distinguish. And unless you have a lot of cells, usually the sensitivity of a urine cytology assay is very difficult to pick them up unless there's a lot of them. So it really is very difficult on cytology. Okay, so this is not a pink renal tumor, but it is one of the newer entities, and I just wanted to mention it today just because we need to keep this in our differential diagnosis because these patients do so well. This is an example of a clear cell papillary renal cell carcinoma, which is its own distinct entity. They're on resection, they're very well circumscribed. There's a very nice border between the tumor and the normal benign renal parenchyma. You can see that there's these cystic spaces within the tumor. As we get closer, it can have a very tubulocystic pattern. And if you look at how the nuclei line up, they're almost like keys on a piano. They're very organized. And you could just walk along, if you were to see them as cobblestones along a creek, you could just step on them and just go along. They're very organized. When you get to the solid areas, it can be confusing to mix this entity with a low-grade clear cell renal cell carcinoma. It's really important to recognize this entity and do some stains to identify it. It can be associated with end-stage renal disease, and some case reports have reported a higher prevalence in African Americans. Like I had mentioned, they've got tubulopapillary architecture, branched glands, small papillary tufts, small papillae. And the cells are very low grade with a piano key appearance. There's definitely no necrosis, no sarcomatoid differentiation. When you stain these tumors, they're going to work positive or CK7 with membranous staining. So if you see, it's got a very nice membranous stain. And the carbonic anhydrase 9 will have this nice basolateral cup-like staining with loss of the apical portion of the tumor. So with these two staining patterns, it's very easy to classify this as a clear cell papillary renal cell carcinoma, and these patients do really well. So it's really important that we recognize them. And that concludes my talk.
Hey, that's great, Laura. So we're still have several minutes. We can cover questions if other people have questions or comments you'd like to bring up. As I mentioned, we will be posting the video later today, the video recording both on YouTube and the link on the Facebook page. And that will include the link to the digital slides that we've used and the presentation.
Thank you all. I had a wonderful time.
Well, we had a great group of people from far and wide, and appreciate all of you who joined us, and always welcome further communications from any of you that may want to reach out directly or individually, either about the topics we've covered today, or if you have other questions, we'll certainly try to help with those as well. We'll plan to do this again next month, usually on the third Friday, barring any scheduling snafus and, and scanners that will work. And we haven't selected our topic for next month, but if you have suggestions for topics or groupings of case types that you'd like to see us cover, we're more than happy to accept your suggestions. So Laura, I don't see any questions popping into the chat box, and we appreciate very much the time you've taken to put these great cases together. And we will look forward to another time when we can share your expertise.
Thank you.